Hi, and thank you for viewing our webinar sponsored by Simon's VIP Connect titled What's in a Name? My name is Heather Rocha, one of the study coordinators for Simon's VIP Connect, and I'm joined by Brenda Finucane, who is the Associate Director and a Senior Clinical Investigator at Geisinger's Autism and Developmental Medicine Institute. Following the presentation, we invite you to submit any questions you have for Brenda by emailing the Simon's VIP Connect coordinator, which is coordinator@simonsvipconnect.org. Now it's my pleasure to introduce Brenda. From the very beginning, Finucane's career has straddled two worlds, clinical and research. While her background is in genetic counseling, Finucane worked for almost 3 decades in a human services organization that focused on special education and psychology and used a non-medical model to provide support services for adults and children with intellectual and developmental disabilities. This background informs her research interests, which bridge the gap between the science of genetics and practical applications to the real world. Finucane focuses on describing and differentiating clinical research findings into practical services that address the educational, behavioral, and health needs of people with genetic conditions. Thanks for joining me, Brenda. I'll let you go ahead and get started.
Thank you, Heather. I'm delighted to be here to present today on some of the confusion that families often encounter when they get a diagnosis of a 16p11.2 deletion or duplication, or a 1q21.1 duplication or deletion, or in fact any other genetic syndrome. Often when families try to take this information into a child's school, they're met with a blank look, and a lot of school systems frankly don't understand what they should be doing with that information. And a lot of times the information is regarded as a medical diagnosis that really has very little relevance for school or behavioral programming. In fact, when we're talking about some of the deletions and duplications and gene changes that are of interest to the Simon's VIP, we know that very often they do affect behavior and they affect learning, so of course they have direct relevance to what's going on in the school. So I'm going to try today to talk a little bit about how the genetic diagnoses that your children have or that you have yourselves fit into the context of a school setting and the types of diagnoses that are used there. First, I should mention that I have no financial conflicts to disclose related to this lecture. And I'll talk really about conditions that affect development, behavior, learning, developmental milestones, etc. So as a group, we term these neurodevelopmental disorders. And so conditions that cause autism or intellectual disability, global developmental delay, speech delays, psychiatric presentations can all be grouped under the heading of neurodevelopmental disorders. They affect the brain and they affect development. And there are many, many hundreds of different causes of neurodevelopmental disorders. In fact, all the kids on this slide have different genetic conditions, and yet they may be categorized as having the same type of neurodevelopmental disorder, such as an intellectual disability or autism. And that's where some of the confusion comes in for schools, because they'll see children who have special developmental needs, and they all may share a symptom diagnosis like autism or intellectual disability, but they have maybe different underlying genetic conditions. So this next slide shows an example of some of this confusion. Here we have 3 kids, and let's say they're all in a developmental preschool class. They've been identified as having developmental delay and an autism spectrum disorder. And yet when you do genetic testing, what you find is the little boy on the left has Fragile X syndrome, the girl in the middle has something called duplication 15q syndrome, and the girl on the right has 22q11.2 deletion syndrome. 3 completely different and unrelated genetic disorders. However, all 3 of these disorders can result in differences in behavior and learning that can become under more general headings of developmental delay and autism. The same is true when you're thinking about school-age kids. So these 3 kids might be in a learning support classroom or a resource room in a class, and all have been diagnosed as having an intellectual disability. All have a diagnosis of autism, and all have been diagnosed with an anxiety disorder. I often say they might have anxiety because they have too many diagnoses. We see as kids get older that they tend to get more and more diagnoses that describe some of their behavioral and learning issues. So it's not uncommon in school age, late teenage years, and also in adulthood to see individuals who have multiple diagnoses. And it gets to the point where it starts to lose meaning when you have 6 or 7 different diagnoses to describe the different symptoms a person has. On the other hand, for these 3 individuals in this slide, there are 3 very specific genetic disorders which are the underpinnings or the underlying causes for their behavioral and learning diagnoses. So the little boy on the left has the 22q11 1.2 deletion, the boy in the middle has Fragile X, and the girl has Smith-Magenis syndrome. So what's going on here? Why are schools really looking at diagnoses so very differently than geneticists people are looking at diagnoses, for example? It boils down to what we call etiology, and etiology means the underlying cause of something. And we now know that developmental disorders, or neurodevelopmental disorders as we call them, are symptoms for which there are many different causes. And genetic and medical factors clearly play a role in causing most developmental disorders. Up until fairly recently, we didn't have a way to check for the genetic underpinnings. We knew they were there, but we didn't have very good laboratory tests. But now with chromosomal microarray and something called whole exome sequencing, we're actually finding lots of different gene changes that are the underlying causes for developmental disorders. So one way to think about this is that a behavioral diagnosis or an educational diagnosis tells you what you're seeing on the outside. So you might see symptoms of a learning disability or autism or a behavioral disorder. And an etiological or genetic diagnosis tells you why the symptoms are occurring. Unfortunately, the bridge between people who are interested in behavioral diagnoses and those who are interested in genetic and etiological diagnoses is not yet complete. And so there's a lot of confusion. And unfortunately, families are right in the middle of that. You may be very invested in information about your child's diagnosis, for example, of a 16p11.2 deletion, and then you go to your child's school and they really don't have any information about it, and they're not sure what to even do about that information. This situation has become particularly acute because we now know that there are many, many different genetic causes of neurodevelopmental disorders. And in fact, if you put together the combined what's called diagnostic yield of some of the testing that we can do now for intellectual disability, for autism, for epilepsy, schizophrenia, and other types of brain-based conditions, up to 40% conservatively can be attributed to a specific known genetic cause. So that's almost half of all these brain disorders that we now can identify a particular underlying cause. And so that situation where you've got a genetic diagnosis and you've got a school or a behavioral diagnosis is becoming much more common. This next slide shows some of the different copy number variants, so these are deletions particularly, that are involved in causing things like intellectual disability or developmental delay, autism, schizophrenia, and epilepsy. And so if you take, for example, a group of laboratory samples that were sent in because a child had an intellectual disability or a developmental delay, what you'll find is those check marks is that every single one of those copy number variants on the left side there, deletions or duplications, have been seen in that population and are known to be causative. But let's say you take thousands and thousands of laboratory samples that were sent to labs because a child presented with an autism diagnosis, and you checked. And sure enough, those same suspects, those same copy number variants, deletions or duplications of various chromosomes, are also implicated for autism. The same is true for schizophrenia. The same is true for epilepsy. So what this slide is telling us is that the copy number of variants that we're seeing on the left side there obviously haven't gotten the memo that there are certain ways that we're defining intellectual disability or autism or schizophrenia or epilepsy. The biology is telling us that they're affecting brain function, and brain function problems can manifest themselves in a variety of different ways. And so clearly the genetic information doesn't know that there's certain criteria that we use to diagnose ID or intellectual disability, or certain criteria that we use to diagnose schizophrenia. All the copy numbers variants are telling us is that this is causing some kind of brain dysfunction, and how it manifests itself will really depend on a variety of different factors. Why is this important? Well, for those of you who have a child with a genetic diagnosis, etiology is important for a lot of reasons. One of the first reasons is genetic counseling for families. You know, if you have a young couple and they have a child with a 17q12 deletion, for example, and it's their first child and they're wondering about completing their family, they want to know, what's the chance of this happening again in the family? Is it 50%? Is it close to the general population chance of happening again? And in order to understand the chance for it happening again, it really is important to know what the etiology is. An example that we can often cite is the chance that you would have a second child with autism. So let's say a child has a diagnosis of autism spectrum disorder, which is a diagnosis that's made based on behaviors that a child presents. And for any couple, once they've had one child with autism, the chance that a second child would have autism is about 10%. However, that's just generally saying overall of all the families with autism. But we know that there are hundreds to thousands of different causes of autism. And for some of those causes, the chance may be no greater than anybody else in the population. And for other causes, the chance may be closer to 50% that another child might have autism. So really knowing the cause helps pinpoint the chance of this happening again in families, and that's really important for genetic counseling. I know for a lot of families, knowing what the underlying cause is can alleviate guilt and misconceptions. When parents have a child who has a developmental delay or some kind of behavioral developmental problem, very often they'll ask themselves, is this something that we did that contributed to it? I know moms often ask themselves, was there something I did during pregnancy? Could I have prevented this? Was that glass of wine I had at the Christmas party before I even knew I was pregnant, could that have caused this? And the vast majority of times, there's really nothing that a parent did or didn't do that results in a neurodevelopmental disorder. These things are out of our control. And so knowing an underlying cause and the fact that a cause may be genetic really can alleviate some of this guilt and misconceptions. There's really no way to control our genes, and it's not that anything we did or failed to do could have resulted in the problem. More and more, knowing a genetic diagnosis is really helping us to customize the medical care of people with certain types of genetic disorders. An example is kids who have a 17q12 deletion, for example, who have a very high chance of having certain types of kidney problems that we can anticipate and try to prevent and monitor if we know that ahead of time. Importantly, knowing about genetic etiologies can also sometimes help provide insights into behavior and learning styles. There's a condition called Angelman syndrome that is often due to a deletion of 15q11 to 13, and kids with Angelman syndrome are typically nonverbal, and they don't develop expressive language. They can understand far more than they can express verbally. But knowing that early on means that we can try to customize their speech therapy so that we're not spending years trying to get them to speak. but we're giving them alternatives to communications right from the get-go so that they can more effectively take advantage of their good receptive language abilities. Another reason why etiology is important is because it helps to focus research efforts. If you're just looking at autism research, just to give you an example, there are so many different underlying causes of autism, it's really hard to have any kind of focused research plan. One type of medication or intervention might work for a couple of kids with the same type of cause of autism, but it may not work for anybody else with autism. On the other hand, when you've really narrowed it down to specific causes like the 16p11.2 deletion or the 1q21 duplication, for example, in the future, it's possible that there may be very specific therapies that are related to that. So targeted research is really important. And then finally, condition-specific support organizations. In addition to SVIP, which pulls together a number of very specific conditions, there are hundreds of support organizations out there for specific disorders. And those really are very, very much customized to the needs of individuals with known genetic disorders. So how did we get to the situation where we've got such confusion around neurodevelopmental disorders and diagnoses? Well, long story short, there are three different disciplines that have been very interested over the decades in neurodevelopmental disorders, and they include psychiatry, psychology, and genetics. But each of these disciplines has been looking at it from a very different lens. So psychology has been interested in the measurement of IQ, for example, and behavior, and really in school systems, it's the psychology discipline that is driving how special education services are playing out and how kids get diagnoses. In psychiatry, there's been an emphasis over the last several decades on medications to manage behavior and to control mood instability, depression, things like that, ADHD or attentional problems. And psychiatry has been interested in neurodevelopmental disorders from that aspect, particularly the idea of pharmacology or medications that might help manage behavior. And genetics from the get-go has always been interested in etiology. What are the underpinnings, or what are causing neurodevelopmental disorders? Unfortunately, these three disciplines, up until fairly recently, never talked to each other. So each of them kind of came up with their own diagnostic categories, etc., without necessarily interacting and sharing their own insights. And now we find them coming together, and in many ways it's like the idea of worlds colliding, because we have children who are getting educational and behavioral diagnoses, but also getting genetic diagnoses, and families, but also professionals, particularly non-medical professionals such as special educators, really are trying to understand how these diagnoses all fit within each other. So in the school setting, typically etiological diagnoses, those are the genetic type diagnoses, are often considered irrelevant. So families will often go to a specific meeting or a conference for their genetic disorder and come home with lots of information and go to the school excited to give this information to the school, and the school will often say, well, send that down to the nurse because that's a medical disorder and doesn't really have implications for us. And instead, in school settings, what we find is that it's the educational and psychiatric diagnoses that are determining the services and treatment approaches. And that's okay, because there are certain classrooms set up, for example, for kids with autism, or there may be certain approaches that really are good for a lot of different disorders. But the emphasis is really on the symptoms and not so much the causes. I do want to define the term psychiatric diagnosis, because psychiatric diagnoses are just the term itself is a very scary one, I think, particularly for parents of young children and school-age children, because when we think about psychiatric diagnoses, most people think about adult-onset psychiatric conditions, not so much about developmental delays, about childhood-onset conditions. In fact, autism, ADHD, intellectual disability, and other conditions are psychiatric diagnoses in the sense that they're defined in the psychiatric manual. So what are psychiatric diagnoses? They're diagnoses that are based on observed, recognizable patterns of human behavior. That's all they are. Psychiatric diagnoses are always behaviorally based diagnoses. So schizophrenia is not diagnosed, for example, by a blood test. It's based on somebody presenting with certain patterns of behavior that we recognize. They're diagnosed using criteria in what's called the Diagnostic and Statistical Manual, or the DSM. And they're clinically determined behavioral diagnoses. So sometimes, a child may be seen by a psychologist or a developmental pediatrician and have a number of assessments, and families give lots of information, and the diagnosis of autism is made, or the diagnosis of oppositional defiant disorder, or obsessive compulsive disorder. Those diagnoses are based on the information you've given about your child and what criteria in the DSM that child meets. They're not diagnosed with laboratory tests. Now, that's not to say they're not important. Psychiatric diagnoses are important because they categorize the symptoms together so that you could have 100 kids, let's say, with ADHD, attention deficit hyperactivity disorder. And even though there's many, many different underlying causes for that, their symptoms are overlapping, and so there may be strategies for addressing ADHD that it doesn't necessarily matter what the cause is. What happens with kids with complex conditions, though, and particularly those with genetic diagnoses, is that often they'll get a number of psychiatric diagnoses and educational diagnoses and also have a genetic diagnosis at the same time. And then it becomes confusing because you may have 6 or 7 different diagnoses over the school age of a child, and it becomes unclear how these all relate to each other. So, for example, you may have a child who's got early on some developmental delays and some behavioral differences. Maybe the child doesn't necessarily like to interact with others or is content to play by himself. Maybe the child has some language delays. And maybe the child gets a diagnosis early on of autism when he's 2 or 3 years old. By the time that child reaches school age, that child is been tested on their cognitive or intellectual functioning, and they're identified as having an intellectual disability. An intellectual disability is what we used to call mental retardation up until a few years ago. And I'll use the shorthand ID since that's how it's used a lot of times in school systems. So a child may have autism, and then when testing is done around school age, let's say 5 or 6 years of age, they're shown to have intellectual issues and meet criteria for an intellectual disability. Maybe the child, as he's getting older, is showing some hyperactivity and some attention problems and gets diagnosed with ADHD. And again, one of the reasons these diagnoses start getting made is often because it's a presenting problem, and for example, you may want some treatments for ADHD. So maybe a psychiatrist is considering putting the child on a stimulant medication for ADHD. Well, you need to have a diagnosis to justify having that medication. So again, an ADHD label gets added, and the child may meet criteria for that. As the child gets older, it may be evident that the child has a mood instability and really pretty dramatic mood swings and may meet criteria for a bipolar disorder. So that might get added, again, often because there may be a medication for mood stabilization that somebody wants to prescribe. But in order to do that, you need to see, does this person actually meet criteria for bipolar disorder? As the child gets even older, maybe a diagnosis of OCD or obsessive compulsive disorder gets made based on some symptoms that are showing. Again, these are all outward symptoms. They get diagnosed on patterns of human behavior. And then ultimately, maybe the child gets diagnosed also with an anxiety disorder. Again, I think they're anxious because they just have way too many diagnoses. Somewhere along the line, and maybe it happens early, but often it happens late. A child may get diagnosed, in this case, for example, with a 16p1 1.2 deletion, which is a genetic cause. And so then a teacher looking at this and a family looking at this might say, how did this child get so unlucky as to have 7 different disorders? Well, the bottom line is this child does not have 7 different disorders. But as you can imagine, the reaction of a parent when she hears that her child has yet another diagnosis is understandable. The child, in fact, doesn't have 7 different diagnoses. Well, does have 7 diagnoses, but doesn't have 7 different unrelated diagnoses. The child has one underlying diagnosis, the 16p11.2 deletion, which results in patterns of behavior and learning that can be called at various times in the child's life these various things. So one can say that, yes, the child has autism. We don't usually like when people say the child has autism and a 16p11.2 deletion because, in fact, the child has autism because of his 16p11.2 deletion, and he has intellectual disability because of his deletion, etc., etc. So there's one underpinning that leads to these other types of diagnoses. Now, I do want to talk a little bit about autism. It's not found in most kids who have 16p11.2 deletions, but it's certainly found in a significant percentage. And for many different genetic deletions, duplications, and single gene changes, there may be a certain percentage who have a brain manifestation that we see on the outside behaviorally as autism. So what is autism? Well, autism, which is more formally named autism spectrum disorder, is a complex disorder of brain development, which is characterized by difficulties with social interaction, verbal and nonverbal communication, and repetitive behaviors. ASD was formerly, up until 2013, known as what's called PDD, and PDD stood for pervasive developmental disorders. And so there are many school-age kids now who previously had a diagnosis of PDD-NOS, and then that was taken away in 2013, and we now call this autism spectrum disorder. There are several subtypes of PDD, and so they included this PDD-NOS, which basically said that, this person has a lot of autistic characteristics but didn't meet full criteria for autistic disorder. You may well have heard also about Asperger's disorder, which was one of the subtypes under PDD. All of these now have either gone away or have been collapsed under autism spectrum disorder in the new version of that DSM, which is the Diagnostic and Statistical Manual for Mental Disorders. So autistic disorder, Asperger's disorder, and PDD-NOS have all 3 of them now come under ASD. There technically is no longer a diagnosis of Asperger's disorder, even though people are very familiar with that as sort of a high-functioning form of autism. But they're all under autism now, or autism spectrum disorder. Rett's disorder and childhood disintegrative disorder have actually gone away completely and were not included at all under the spectrum of autism in the newest version. So I'm just going to very quickly go through what the current criteria are for ASD. There are a number of different manifestations that have to be present in order to meet criteria for ASD. The first one has to do with problems with social communication and social interaction across multiple contexts, so in school and at home and in different situations. And so what might happen with a child with ASD is they have some problems with social or emotional reciprocity. What that means is that you may interact with the child, but the child is not interacting back. You give the child a big hug, the child may not hug you back. So there are problems with reciprocating social or emotional interaction. Children often with ASD have problems with using nonverbal behaviors for social interaction. So some of the earliest signs have to do with pointing. For example, typical 2-year-olds often will point even before they can speak well to show somebody what they want them to look at. But you may not find that in a child with autism who may not be using those nonverbal gestures to communicate. There's often a problem in developing, maintaining, and understanding relationships, particularly social relationships. Now, not every child with an autism spectrum disorder will meet or have problems with all of these different areas, but they have to at least have some deficits in some of these areas for this first category in order to meet criteria for ASD. A second area where there are criteria for autism spectrum disorder, have to do with restricted and repetitive patterns of behavior, interest, or activity. So you have to have at least two of the following. You have to have stereotyped or repetitive motor movements, use of objects, and speech. What that means is stereotyped means doing something over and over again, and it's a type of non-functional or repetitive motor movement that's not meaningful in terms of communication or use. So an example is hand flapping, for example, using objects in unusual ways, lining up cars, etc. Or speech, that means saying the same thing over and over again, or repeating what other people say. Another example would be insistence on sameness, routine, and ritualized patterns of verbal or nonverbal behavior. So doing the same thing over and over again and insisting on this and getting very upset when that routine is changed. Highly restricted fixated interests that are abnormal in intensity or focus. And I will say here, a lot of typical kids go through periods where they watch the same video over and over again, and then eventually they get to the point where they're not watching it anymore. So, is that completely abnormal? Well, it's actually pretty typical of a lot of children. But when it becomes so fixated and so restricted that it's something that has to be done many, many times a day, and it causes a lot of distress when a child can't engage in that type of ritual, then one wonders whether it's actually something more on the autism spectrum. Many kids with autism are either hyper or hypo, either over or under sensitive to sensations from their environment. So they may have an unusually strong reaction to certain smells, or they may get very, very upset when there's loud noises, more so than other kids their age. So if there are at least problems in two of these areas, then a child may meet criteria for an autism spectrum disorder. The other important criteria is that these symptoms have to be present in the early developmental period. So, if a child is 11 and all of a sudden at 11 years starts to get very sensitive to noises and other things, one can't say that they suddenly developed autism. Autism is an early childhood onset issue that's actually there from before birth and starts to manifest itself very early on. The symptoms have to cause clinically significant problems, or else it's not a disorder. Many of us know adults and may actually think about ourselves as having some of these symptoms, but we're able to function, they don't cause us significant impairments, and we really kind of had workarounds around some of these symptoms. We're all humans. Many of us share lots of these symptoms. It's only when the symptoms cause clinical problems that it's a disorder. And then it's important to know that, a lot of kids who have an intellectual disability, again, what we used to call mental retardation, or a global developmental delay, a lot of times they'll have some of these symptoms, and it's not necessarily autism. It's really because developmentally they're at a much lower level than their chronological age, and so we're seeing some of those behaviors. And for autism spectrum disorder, the DSM kind of puts these things into different levels of severity, and depending on what level they're in, it may mean how many supports that they require. So we can, in a nutshell, say that there are children who have autism who are very high functioning, and then we have others who have more challenges and need more supports. So for autism, we can say that there are those criteria, and that's how the diagnosis gets made. The other criteria, or the other diagnosis that's important to know about when we're talking about genetic conditions, is intellectual disability. Again, formerly known as mental retardation, and because that term became very pejorative or negative, it was phased out, and now the term intellectual disability is used. And there are certain criteria that have to be met in order to have a diagnosis of ID. There are different definitions of ID, but this one is from the Psychiatric Manual, and this is how the DSM defines intellectual disability. So there are three main points here. One is that you have to have deficits in intellectual functioning. So typically this is measured using an IQ test. The average IQ of people is 100, and so if you have an IQ of 70 or below, 30 points below the average or lower, then you've met one of the criteria for intellectual disability. The second criterion has to do with deficits or impairments in adaptive functioning. And what this means is, well, how do these problems manifest in your everyday life? Do they impact your ability to be independent or navigate your environment? Does it impact, do you have problems with communication? Do you have problems with social skills? How about personal independence, your ability to dress yourself, make a sandwich, or navigate your community independently? Do they impact your school or work functioning? Because it's not enough to just say that a person has an IQ below 70. Does it actually cause impairments in your everyday or adaptive functioning? And the third criterion has to do with when these symptoms first start showing themselves. So for intellectual disability, the onset has to happen during the developmental period, which is up to around age 18 years. If you have a problem after that time period that gives you some of these deficits, well, you don't have intellectual disability. And so I'll give you an example of that here. If we think about the average IQ of people in the United States, the average IQ is 100. There's nothing special about people in the United States that makes the average 100. The average is 100 because we said so. That's the way the tests are structured, that the average will always be 100. If an IQ test didn't have an average of 100, it wouldn't be a very good IQ test because that's the way they're set up and structured. And in fact, if the people in the United States, for example, got much smarter, they'd have to make the questions on the IQ test tougher so that the average would remain at 100. So there's nothing magical about the IQ average being 100. That's the way the tests are set up. Now, the cutoff for intellectual disability has been determined to be 70, not because there's anything magical or anything biological about 70 that makes a difference between ID and non-ID, but that's just been the determined cutoff. In fact, many years ago, it was determined that intellectual disability, what they used to call mental impairment back many, many decades ago, that the cutoff should actually be 15 points below 100 or 85. And so for a number of years, the cutoff for ID or intellectual disability was an IQ of 85. And if you can imagine, that meant many, many more thousands of individuals in the United States met criteria for intellectual disability. And that meant that at that time, back in the 70s, 16% of the U.S. population actually had what was called mental retardation back at the time. Well, clearly that cost tons of money. The idea was, let's identify more people having that particular disability so that we could provide them with more services. But in the end, it ended up being a very big proposition when 16% of the United States qualified for all kinds of services, and so they cut it back down to 30 points below the mean IQ. So currently, the cutoff is around 70. And that means that if you score under 70 and you have deficits in adaptive behavior, and if these things were present before the age of the developmental period up to age 18, then you meet the cutoff for the criteria for intellectual disability. Of interest, on the other side of the IQ curve is the gifted range, and so that cutoff is also 30 points above the average. Again, by convention, it's an artificial cutoff that gets set so that we can determine who are the percentage of kids who have very high IQ who maybe need some gifted services. Again, these are all determined by society. These are not biologically determined cutoffs. So just so that you know, intellectual disability is not a biological definition. It's a definition that we as a society have made in order to identify who are the 1 to 2% of the population who have the most extraordinary needs and will qualify for services. Finally, I'll talk about schizophrenia, since this is an adult-onset psychiatric condition which sometimes manifests in people with different types of copy number variants, particularly deletions and duplications of various chromosomes. People get very concerned when they hear the term schizophrenia, so I do want to demystify this. Schizophrenia is a brain disorder that affects how people think, feel, and perceive the world. The hallmark symptom of schizophrenia is psychosis. Psychosis meaning losing touch with reality, such as experiencing auditory hallucinations or voices, and delusions, fixed false beliefs. So schizophrenia is a major psychiatric condition. Again, it's a brain-based disorder. The typical onset is about 18 years in men, and it's later in women. And the symptoms can be divided into different types of areas, whether you have hallucinations, usually involving things you're hearing, or auditory hallucinations, delusions, things you believe that are not real, disorganized speech and behavior. And then there are negative symptoms, so depression-type symptoms, decrease in your emotional range, loss of interest and drive, being unusually quiet. And then there are intellectual or cognitive symptoms. So you have problems with your memory and attention, problems with organization, difficulty understanding interpersonal cues and relationships. And then there are problems with moods, symptoms, cheerful or sad in a way that's difficult to understand and often depressed. So these types of symptoms go along with schizophrenia, and very often it's a gradual onset that becomes very obvious when it's fully present. Again, typical age of onset is in the late adolescent and early young adulthood. So it's important to know about those diagnoses, because when you read about different genetic conditions, you hear that it may be associated with schizophrenia, may be associated with intellectual disability or autism. But again, those are the behavioral manifestations of certain genetic conditions, and they're certainly not present in everybody who has a genetic disorder. So what conclusions can we draw from this? Well, diagnostic confusion abounds. There are a lot of problems in the school settings with understanding how genetic diagnoses fit in to IEPs and behavior plans, etc. Psychiatric and behavioral symptoms are found in association with many genetic disorders, including 16p11.2 and 1q21.1 deletions and duplications, as well as others. And it's important for parents and professionals to understand the distinction between symptom diagnoses like autism or ID or ADHD, and cause diagnoses, which reflect the underlying genetic cause. For schools, we need both types of diagnoses. We need educational and behavioral diagnoses, not genetic diagnoses especially, to determine eligibility and services within the school setting. So I've had families who've asked, well, now that we have a genetic diagnosis, does that mean we don't need the autism diagnosis, or we don't need the intellectual disability diagnosis? Well, frankly, a genetic diagnosis is not really going to be the thing that drives the services in the school settings. You also need those symptom diagnoses so people can better understand what's the best type of classroom placement, what are the best types of supports a child might need. We know that individuals with deletions and duplications often meet criteria for one or more behavioral and educational diagnoses. So they may have a 1q21.1 duplication and have a diagnosis of a learning disability and autism, let's say, and maybe ADHD. On the other hand, we want to use those diagnoses for everything they're worth, realizing that the deletion and duplication is the underlying reason for those symptoms, but that those symptoms may help us to guide what type of school services are available. Now, it's important to know that schools and teachers are unlikely to be familiar with these deletions and duplications, and that's okay. I've heard parents say, well, we don't want to send our child to the local school because when we went there, they never heard of the 16p11.2 duplication. Well, schools all over the country have never heard of these duplications and deletions, and they don't necessarily mean that they can't provide excellent services. They often can provide excellent services, and what you need to look for is do they have an open mind and a willingness to learn new things about the genetic diagnosis, particularly the behavioral aspects and the practical aspects of the genetic diagnosis, and do they have a creative approach to meeting a child's needs. These are just as important as experience with the specific genetic condition. The last thing I'll mention about that is that I've had calls from families who say, well, can you recommend a school that has experience with this particular genetic disorder? And I would certainly caution families against trying to travel around and find schools based on their experience, because first of all, Most schools do not have experience with these genetic conditions. Second of all, the services are being driven really by symptom diagnoses, and that's what you have to pay attention to. And I would really much rather have a teacher who's very willing to learn and understand how the genetic diagnosis is fitting in with the symptom diagnoses than one who has had experience, let's say, with one of these deletions or duplications, but really has very rigid ideas about how to support a child. So relax if your local school district seems to be doing a very good job and you're wondering, is this okay? Yes, it is okay. Most school districts really are not going to know about these genetic diagnoses. And again, it is our role as professionals in genetics, but also your role as parents, to try to educate them about some of the practical considerations they need to understand for your child's best development in school. I'd like to acknowledge all my collaborators at ADMI, which is the Geisinger Autism and Developmental Medicine Institute out in Lewisburg, Pennsylvania, in the center of PA. We see a lot of children with different genetic disorders here, and a lot of work has gone into helping the work of SVIP, and of course Geisinger is intimately involved with the Simons Project as well. And now I will turn it over for a few last words to Heather Rocha.
Hi, Brenda, and thanks to everyone for viewing our webinar. Please remember, if you have any questions, you can submit them to Ms. Finucane through us at coordinator@simonsvipconnect.org. Thanks again.